Hi everybody, and welcome to your July webinar hosted by the National Drug Research Institute. I'm Samantha College Frisbee. I'm a research fellow at NDRI, and our topic today is the unmet sexual, reproductive and parenting needs of women who use substances. And I'm really delighted to be joined by three incredible women across the sector. So Dr. Ash Stewart is a research fellow from the Burnet Institute. Dr. Jocelyn Chan is an addiction physician from Western Health and a research fellow at the Burnet Institute. And Louise Hughes is our peer support coordinator from the Canberra Alliance for Harm Minimisation and Advocacy. Now today our topic is broad, but a lot of my interest in the clinical and social health of women who use drugs is actually due to the research that Ash and I have been conducting among our cohort of people who inject drugs in Melbourne. And today she's going to be presenting on some preliminary work on the prevalence of contraception use, pregnancy and terminations among this population. So I'm going to first hand it over to you, Ash.
All right, thanks, Sam. I think my presentation looks good. Someone can give me a thumbs up. I'm going to assume. Excellent, fabulous. Thanks so much for the introduction and thanks for having me along today. As Sam said, I'm going to talk a little bit about the unmet sexual and reproductive health needs of women who use drugs. I thought it might be helpful to start off with a little bit of a context around the motivations for why we started looking at this research. So we know from recent prevalence estimates that about 2.8 million women worldwide inject drugs. AOD research and harm reduction services have historically been quite male-focused and designed around the experiences of men. There are no women-specific harm reduction services that currently exist in Australia. We definitely have some great women initiatives, but we don't have any services that are just specifically for women. Even though we know that the prevalence of injecting drug use among men has been higher over time, we are seeing this gender gap starting to narrow. And we do know that women experience quite different patterns of drug-related harm than men. So this is things like some emerging evidence that we can see around higher incidence of bloodborne viruses, lower treatment uptake compared to men. We know that women more commonly report childhood trauma and gender-based violence. We know that women experience stigma quite differently to men, and this is often driven by perceptions of social roles as mothers and caregivers. We know that women are more likely to live and care for children than men, and we also know that women are more likely to exchange sex for money and drugs than what men are. And this emerging evidence is also suggesting that women face poorer health and social outcomes than males who use drugs, and also, of course, women in the general population. And this is driven by a lot of these things that I've just mentioned.
Ash just dropped off.
Am I back?
Yes. Okay, I wasn't sure if that was my computer. You're back, Ash. Thanks.
It's feeling.
I'm so sorry. Am I back?
You are, Ash. I wonder if it might be good for you to just turn your camera off. That might help.
I can. I'm so sorry, everyone online. I've just lost internet in my office, but I think I'm back online. I'll turn my camera off for a second and hopefully I can press on. If that happens again, go to the next person. We'll come back to me. So what we know around some sexual and reproductive health research around women who use drugs, we've seen some research looking at menstrual poverty among this group. We do know that there's unintended pregnancies and terminations that occur among this group. Kirsten Black has done some of this work out of Australia, but it was a little while ago. We do know that there's poor pregnancy outcomes and early onset menopause. The existing literature is pretty outdated though. It does typically involve women who are in treatment, AOD treatment, so not always among cohorts of women who are actively using drugs, and often does include small sample sizes. So there's definitely a lack of contemporary evidence, and particularly within the Australian context. So I'm going to talk a little bit first about hormonal contraception use. So we know that hormonal contraception is a really key component of women's healthcare everywhere. We know that reproductive choices for women who inject drugs does occur in this context of the things that I spoke about earlier, so instability, violence, disrupted access to care. Many women use hormonal contraception for non-contraceptive indications. So this is things like menstrual pain, cycle regulation. Some women also use it for skin. And we know that contraception supports this reproductive autonomy and reduces unintended pregnancy and really helps women with family planning. So among women who use drugs, there was some studies that showed up to 85% of women reported having an unintended pregnancy. And this was quite a lot higher than what we could estimate as around 25 to 30% of women in the Australian general population. So when I talk about contraception efficacy, for anyone online who is not so familiar with this, so this is often expressed as the number of women out of 100 who may become pregnant within a year of using a method of contraception. And so we have these different tiers of contraception. So our highly effective or tier 1 methods are what we refer to like implants and intrauterine devices that result in fewer than 1 pregnancy per 100 women annually. And then we have this tier 2, so pills and hormonal injections, and tier 3, so things like condoms, diaphragms, and sponges. And the ones that are circled today are what I'm going to talk a bit more about. So what we wanted to do was estimate the prevalence of hormonal contraceptive use among women in our supermix cohort, and we looked at it between 2008 and 2022, and we looked at overall and by type of contraception. So we included women who reported female sex at birth, who were of reproductive age, so 14 to 44 years, and we aligned this with what the ABS includes as reproductive age. And we included women who had initiated injecting drug use prior to or during the study. And we looked at PBS dispensation records for contraceptions and then MBS records for contraceptive procedures. So this is like going to the GP or medical practitioner to have an intrauterine device or an implant inserted. So the key findings, we had 62% of women in our cohort who had any hormonal contraception dispensation or procedure over the study period. When we looked at this annually as a prevalence, it was about less than 10% of women in our cohort versus almost 30% in the general population that we know annually use hormonal contraception. The methods were quite mixed, but definitely dominated by short-acting methods. So that's our tier 2 that I'm talking about in terms of pills and our injections versus our long-acting reversible methods. So that's our IUDs and implants. Thinking about some of the practical barriers that might contribute to why we see higher short-acting method use versus our tier 1 methods. So we know that there's quite a cost variation for IUDs and versus pills. And we also know that there's longer wait times for IUDs. So often you have to go to the GP and have a consultation and then come back for another consultation to have it inserted versus the short-acting methods where you can go to the GP and you can walk out with a script for the pill. And we have a little bit of data in the study that just self-report data around menstrual pain among women in supermix. So we just had a bit of a crude look at this and we found that women who used hormonal contraception had reported higher menstrual pain, and it's probably more likely that it's reflecting an indication for going on contraception versus an adverse effect, but something we need to have a bit more of a look at. We wanted to look at this around general trends in our cohort, so by age and birth cohort. So we looked at different methods, our tier 2 versus tier 1 methods, and we looked at it by age of women and then within different cohorts, so women born in the 60s, in the 70s, in the 80s, and then the 90s. And what we found was our older birth cohorts were predominantly using short-acting methods. And by the time we got to women in the 90s, we did see a slightly higher uptake of long-acting reversible contraception. But despite this overall improvement, definitely we're seeing much lower use of hormonal contraceptive methods versus our general population, which may indicate a bit of a persistent unmet need among this group. So switching across now to terminations and pregnancy hospitalisations. So why does this matter? High unintended pregnancy can lead to termination rates, and we know that terminations of pregnancy can be really traumatic for women and are linked to poor physical and emotional health. There's a bit of international evidence that shows that among women who use drugs, 40 to 50% have reported having a prior termination of a pregnancy. And there's also a bit of work that looks at higher risk of preterm birth, low birth weight and complications among cohorts of women who use drugs. There's really no Australian longitudinal data that's looked at this, so we're hoping this work that we're currently doing is going to fill this gap. And what we aim to do was estimate the incidence of pregnancy terminations and also have a look at fertility rate. And we wanted to describe births and complications among our cohort. So how we found or looked at this within our cohort, so we used linked data to the PBS and to hospitalisation records. So to identify terminations of pregnancy, we looked at PBS records for medication dispensations of combination therapy for early medical termination. So this is up to or less than 9 weeks gestation. And this medication was approved in Australia in 2012, but it wasn't listed on the PBS until 2013. And we also looked at ICD-10 coding for surgical termination. So this is terminations that typically occur up to 13 weeks gestation. And then for births and complications, we used ICD-10 coding for hospitalisations for pregnancy and childbirth. So terminations and facility first, we had 217 terminations across the cohort in the years that we looked at between 2008 and 2022. And 8 of these were medical and 209 were surgical, which could be mostly driven by the fact that medical terminations were only approved in 2013. 27% of women had a pregnancy termination, and the crude rate was 37 per 1,000 person years, which was more than double what we see in the population. And I'll show you a figure in a minute that will show that a bit more clearly. We looked at the mean age at termination, which was 29 years. And then when we calculated the fertility rate, we actually find a rate much lower than what we see in the general population. So it was 0.5 births per woman in Supermix. So this was the plot that I was talking about. It just shows a bit of the sort of crude incidence rate over time. I've just popped the mean ages there so you can see that we do have our cohort aging over time. So taking that into account, it probably does make sense that we see this sort of increase in the middle there and then it being a bit lower. But the main takeaway from this plot is that Australian estimate that we have that we could really only find in those later years. We couldn't find estimates that were much earlier than that, but it is just quite a lot lower in the general population. And then finally, some birth outcomes and complications in our cohort. So we had 44% of women in our study who had a pregnancy record and 31% who had ever given birth or at least had a record of birth in the study. We didn't look at self-report data for this at the moment. This is just using hospitalisations data. 90% of women who gave birth had an ICD-10 code for a complication, and 23% of births involved preterm labour or delivery. And this is roughly about 3 times higher than what we know as the general population prevalence. Hospital stays were longer than population norms. Hospital stays are a little bit tricky to always understand what's going on because there's many reasons why the stay could be longer, but we can use it as a bit of a crude proxy to understand whether or not a birth and a pregnancy went to plan versus if complications happen and it might have required you to stay in hospital longer. And some of the common issues that we found in terms of complications were preterm labour, abnormal labour, hemorrhage and fetal distress. So I guess the main takeaway here is that most births occurred in a pretty high risk clinical context and definitely requires us to do a bit more work to understand this further. Before I hand back to Sam, I just want to finish on a little quote that was said at INSU many years ago, and I've just repeated it so many times because I think it is really important for us to remember in the work that we do. But women who use drugs are not just the female version of men who use drugs. So we need to keep chipping away at understanding this cohort of women a bit better. Thanks, and sorry for the tech issues.
We're just sorry we couldn't get to see your face, Ash. Thank you so much. That was really wonderful. It's really nice to see that all kind of packaged together, and to, I guess, see like the narrative of reproductive health for women who inject drugs. So next, I'm going to be handing over to Jocelyn Chan, who is an addiction medicine physician working through Western Health, but also holds a post as a research fellow at the Burnet Institute. Today, she's going to be talking about the cycle of child protection service involvement in the lives of people who inject drugs, including some research findings. But I've also requested that she talks a little bit about her clinical experience as well. So she's kind enough to do so. Thank you so much, Jocelyn. I'll hand it over to you now.
Thanks so much for the introduction, Sam, and the opportunity to speak here today. So I'll mostly be talking about a paper that I worked with a couple of the co-authors listed there on about parents who inject drugs, and particularly looking at correlates for child placements to out-of-home care. And I note that this analysis is not specific to women, but there are some interesting differences between men and women in the results. And then, as Sam discussed, I'll share some of my clinical reflections as well.
Sorry, Jocelyn, we're not seeing your PowerPoint slides. I think that's right.
Oh.
Are others seeing the slides?
I'm just trying to bring content on the screen, but it's... Sorry, Jocelyn.
That's all right.
It's like they're separate or something. Do you want to try sharing them again?
Yeah.
Bear with us, everyone, as we try and sort this out.
What's showing up there?
I'm getting an error saying couldn't bring them on screen. Try again. But I think there's a new Teams event interface, and here we go. This is right. There we go.
Is that better? Is that working now?
It's
Not
working quite yet for me, but it feels closer than it was. I'm sure I'll catch up, Jocelyn. I think maybe just keep working through it, and we can we'll figure it out on our end.
Okay. So I'd like to acknowledge we're all on unceded Aboriginal lands, and I'd like to pay my respects to the Wurundjeri people of the Kulin Nation on whose lands I'm speaking from today, and pay my respects to elders past and present. How's the slides now?
Someone in the audience said that they can see them, so I think we're good.
Oh, okay, great. All right, so as a bit of an introduction, children in families affected by substance use disorders are at high risk of removal to out-of-home care. About 60% of Australian children in out-of-home care were removed from households affected by substance use disorders. And removal to out-of-home care is associated with poor outcomes for parents and for children. So there's plenty of systematic reviews showing associations with poorer outcomes for children who are placed in out-of-home care, and also some emerging studies showing that loss of child custody affects maternal health with increased rates of substance use, overdose, mental illness, trauma, and mortality as well. I'd like to note as I present that parental drug use is not equivalent to child neglect, and that while parental drug use can be a risk factor for poor outcomes, there are many children in families with histories of drug use that reach adulthood without those poor outcomes, and that any association between parental drug use and child outcomes need to account for a range of different factors, including the fact that injecting drug use co-occurs with other indicators of marginalisation, and that the stigma associated with drug use itself impacts on access to care, especially for women. And and that there is a lack of evidence on the needs and characteristics of parents who inject drugs. So what we did in this study was describe the socio-demographic, health and drug use and parenting characteristics of supermix participants. So this is a cohort of people who inject drugs. And we looked at associations for removal of children to out-of-home care. And with a particular look at parents' own childhood out-of-home care status to look for this intergenerational association. So we used the same prospective cohort study that Ash has already mentioned. It was over 1,300 participants. They're all over 18, and when they were recruited, were injecting at least monthly. And they've been followed up with annual interviews exploring demographics, drug use and parenting characteristics. And what we've done in this study is describe the cohort characteristics by parental status, and then also looked at correlates for out-of-home care among the children. So what we found in this cohort is that parents and carers were more likely to be women, more likely to be Aboriginal or Torres Strait Islander, have lower levels of education, be unemployed, and have stable accommodation. Interestingly, parents and caregivers had similar patterns of drug use to those who were not. So similar age at first injection, same illicit drug use of choice, which was heroin, and similar injecting frequency in the past week. However, parents and caregivers were less likely to report hazardous or harmful levels of alcohol consumption. A substantial proportion, around a quarter, reported a history of out-of-home care as a child themselves, and with even higher proportions among our Aboriginal cohort, with over 60% of those who are parents report being a member or a child of the stolen generation. So women were more likely to have children living with them, but they also reported much higher levels of child protection involvement. So 70% of the mothers in our cohort reported child protection involvement, and 64% of the mothers reported child removal. However, men were more likely to have no access rights to at least one child. These are the results from our analysis looking at correlates for child removal. After adjustment, we found that the characteristics associated with having at least one child in out-of-home care were being female, being Aboriginal or Torres Strait Islander, having experienced assault, and having a higher number of children. And for women specifically, incarceration was associated with a 7 times increase in odds of removal to out-of-home care, while being on opioid agonist treatment was protective. We found that being removed as a child was associated with a 4 times greater odds of having a child than of their own in out-of-home care. So it was clear that this risk is translated across generations. So to summarize some of the results from this quantitative study, there were incredibly high rates of child protection involvement and child removal to out-of-home care among parents who inject drugs. Women face nearly double the rates of child protection involvement and removal. And interestingly, from our analysis, child removal is primarily driven by social and environmental factors rather than the drug use factors, which were also a part of that analysis. In particular, incarceration is associated, with a 7-fold increase odds of child removal. However, I guess the silver lining is treatment engagement may protect family preservation. And then also a key finding of our analysis was that out-of-home care is intergenerational. So I guess what I wanted to provide from my clinical reflections is a bit of context about what's happening from my perspective for these women who are experiencing these adverse events. What I've heard from consumers or clients is that child protection orders come with little to no associated support, and that there's an expectation of abstinence, often measured through urine drug screens or blood alcohol level testing. And as a parent myself, I know the adjustment to parenthood is already challenging, and these parents also then face the difficulty of navigating AOD treatment and or family violence support systems on top of that in order to meet these child protection orders. And some of my thoughts as a clinician was that what happens in terms of child protection processes and decision making is often really opaque to me. There's really limited communication by default. So I am sometimes contacted to provide information, such as whether or not patients are attending appointments, but I get little information on what their concerns might be, or how that information is then used to make decisions. There's some dedicated support prenatally for women in Victoria. So there's antenatal services with AOD care included, but minimal post-birth support available. And I absolutely think there's a greater role here for clinician advocacy. So I want to especially acknowledge Elvira Sekutanis, who's our peer lead for the AOD peer workforce at Western Health, who has been really proactive in advocating for our patients, and she proactively engages with child protection to advocate for our patients. And I absolutely think that we should all be doing more of that, given how challenging it is to navigate these systems. So some final reflections: that further research and definitely intervention is needed to support parents who inject drugs, and that our efforts should address the health and social inequities affecting this cohort as well. So this is the paper if people are interested to read a bit more. Yeah, thank you.
Thank you so much, Jocelyn. And very sorry, I think Teams has just updated itself and there's a bit of a glitch with sharing slides through the PowerPoint live. And so I think Louise is sharing her slides through the old method anyway. And so I'm sorry, Jocelyn, I think some people got to see your slides and some people didn't, but you spoke to them incredibly well. So I'm not too concerned about information getting missed. But if you would like, to see those slides, I'm sure contacting Jocelyn is no issue, and getting those slides off her is no issue at all. So very, very excited to introduce Louise Hughes. So this session was actually born out of a conversation that I had with Chris Goff at CAHMA about the work that Louise and others on her team are doing there around peer support through family reunification for parents engaged with their service. So I'm so grateful that Louise is here to discuss this really important program with us today, including her own success. So I'll pass it over to you, Louise. Thank you.
Thank you. Just want to double check everybody can see the slides. All good? Can you hear me? Sorry.
I can hear you.
Oh, okay. Can you see
I'm
the
just not too sure. I can't see slides. Sorry. Can we just get someone in the Q&A to let us know that they can see slides? Because I don't think I can. Oh God, this is such a pain. Did you share it through did you share your screen, Louise? Oh, you can. Okay. So
they can see it?
They can see it.
Okay, cool. All right. So yeah, today I'll be here to talk about CAHMA and the peers that are using their lived experience in the child and protection space. I'd like to acknowledge the traditional custodians of the land on which I'm meeting on and pay respects to elders both past, present and emerging. Just for a bit of context, my name's Louise. I'm the Peer Treatment Support Manager at Canberra Alliance for Harm Minimisation and Advocacy. I have the privilege of leading a dedicated team of peer workers who support people who navigate alcohol and other drug use, recovery and involvement with the care and protection system. My passion for this work comes from my own lived experience. There was a time in my life where I experienced problematic substance use, homelessness, and significant involvement with child, youth and protection. I know how it feels to be judged, lose hope, and to believe that things may never change. So in 2018, I came to Canberra following the second removal of my son. At that point, I had little hope that he would be restored into my care. I was carrying great shame, grief, and an uncertainty, but I also knew something that needed to change. Today, my son lives with me in Canberra, and I'm very proud of that. My previous experience impacts my role daily. My work is grounded in the belief that people are far more than the worst things that has happened to them. When we create environments that are safe, non-judgmental and built on genuine connection, people can achieve incredible things. Every day I have the privilege of witnessing people rediscover their strengths, reconnect with their families and create positive change in their own lives and in their communities. So for me, peer work is more than just a job, it's my identity. It's about walking alongside people, offering hope through shared experience and showing that recovery, if they choose, healing and meaningful change is possible. Oops, sorry, my bad. So as we know, there's been a bit of history with the sort of care and protection space. In the 1990s, we had parents and children's clinics began. Moving into sort of the 2000s, services evolved to include stronger advocacy. In 2010, we had Jude Byrne, who is a huge advocate for lived experience in this space. So that brings us to today and how we do it at CAHMA. So we're a peer-based service such as us. We play a vital role in supporting parents who use drugs and use drug treatment services by providing a safe space, advocacy and practical assistance. CAHMA's peer treatment support service workers in the ACT continue to build on the legacy of others, ensuring that the needs of parents remain visible, that stigma is always challenged, and that services continue to be grounded in compassion, empathy, respect, and genuine understanding. So it's pretty clear that historically the people who use drugs are laced with stigma and discrimination. There are a lot of widespread assumptions that drug use equates to poor parenting, which is not true. And then there is a lot of lack of understanding and awareness of the linkage between parents' well-being and the child's well-being. So CAHMA peer workers fill that gap. Through identifying these key issues, CAHMA recognises the lack of CYF harm reduction service provision, which the Canberra Alliance, which CAHMA successfully fills through its peer work. By focusing on the health and well-being of the parent and recognising that supporting parents leads to better outcomes for children. So how CAHMA does this? So we do the one-on-one assistance with the parent. We support them with navigating complex and often intimidating care and protection systems. We draw on our lived experience and help build trust. We offer practical advice which is relevant and realistic, and we stand alongside the parent as they engage with services. This unique position allows CAHMA not only to support individuals, but also to identify recurring barriers and systematic gaps that impact many families. So over time, we've used community consultation, and we are very big on building our partnerships with, in particular with care and protection. So CAHMA's worked deliberately to shift the culture of services around care and protection involvement. Through regular dialogue, training and collaboration initiatives, CAHMA has built relationships with care and protection staff and other service providers. So through ongoing collaboration, the peer workers at CAHMA have established themselves as a bridge between families and the services that they engage with. The organisation's success lies in its workers and their ability to build trust, reduce fear, and place parents' dignity at the centre of harm reduction. So as you can see here, I started here back in sort of 2019, and since then our not just due to me, us and the team around me, our referrals have significantly increased over time. So peer treatment support services, we are unlike any your traditional AOD service. CAHMA does not provide clinical treatment or counselling. Instead, we offer something equally important, a relationship built on shared understanding, hope and trust. Our peer workers have first-hand experience of navigating recovery, and many have, or all of them have lived experience of engaging within the child protection space. Sorry. So when what that looks like on the ground, we're helping our clients understand care and protection processes. We prepare them for meetings, we go to case conferences, and we also help attend court. So, and we also work collaboratively with the multidisciplinary teams while ensuring the client's voice remains central. We provide support around transport and outreach where appropriate, reducing barriers to accessing support. So CAHMA's peer treatment support program and the child protection element of that. So our approach is a trauma-informed, person-centred, strength-based and guided by harm reduction principles. We recognise that recovery is rarely linear and that sustainable change takes time. Rather than focusing solely on an abstinence-based side, we support people to make meaningful change that improves safety, well-being, parenting capacity and overall quality of life. The flexibility of our peer treatment support model allows us to respond quickly to changing circumstances, provide outreach in community settings, and maintain engagement during periods when clients may otherwise disengage. This continuity of support is particularly valuable for families involved with care and protection, where consistent engagement can significantly influence outcomes. So ultimately, CAHMA's peer treatment support program bridges the gap between clinical services and real-life recovery by combining lived experience with practical advocacy and systems navigation. We empower parents and carers to build confidence, strengthen their protective factors, engage with services, and work towards achieving the best possible outcome for themselves and their children. Thank you.
Thank you so much, Louise. That was really wonderful to hear about the program.
Yeah.
And I just want to invite everybody, so Ash and Jocelyn, back on and just say thank you to everybody online for bearing with us with PowerPoint slide gate. Bit of that doesn't matter how well your pre-webinar check-ins go, nothing can quite equip you for the live event. But thanks to everybody for just doing such wonderful presentations. I feel like the slides were going to just be an added bonus anyway. So I just welcome everyone to submit through the any questions through the Q&A. I haven't seen anything come in apart from, yes, I can see slides. No, I can't see slides. Yes, I can see slides. But please, if you have any questions for our presenters, please submit them through the Q&A. But I am going to ask a couple of myself, if that's okay. So I'm going to start with you, Ash. So obviously we know that people who inject drugs are an aging population, have been kind of called an aging population, particularly in high-income countries. Is this something that we kind of need to keep in mind when we think about sexual and reproductive health for the women in this group?
Yeah, thanks, Sam. I think that's a really great question. Obviously, we can see that our supermix cohort is definitely aging a little bit over time. Whether or not that is entirely true for injecting drug use more broadly in sort of the global space, but for us here, we are seeing that a little bit. We did a study, qual study a couple of years ago now, where we actually interviewed a bunch of women in supermix and spoke to them about their sexual and reproductive needs quite broadly. And we didn't limit that study to specifically asking about contraception or pregnancy or anything like that. We kind of let women talk to us about what their needs were. And actually menopause came out a little bit in that work. They sort of labeled it as the next big thing. So I think that that's probably something that we need to think a little bit about and consider. Some women reported feeling not very well informed with that and didn't really know what to expect or how to prepare. So I think that that's like a really important thing for us to think about. One of the other things that came up a little bit that I can remember in the work was also women saying that being on certain medications like OAT mimicked symptoms that they had of menopause, like hot flushes and things, which made it really hard for them to identify what was perhaps medication side effects versus symptoms of menopause that they couldn't kind of notice or identify and then speak to their GPs about. And one of the other things that I think is a really important point was that women had this fear that hot flushes might be misidentified as something to do with their drug use rather than menopause that they were quite worried about. So I think that space really deserves probably quite a bit of work to unpack a bit further and understand.
Yeah, right. And it kind of just, that last point in particular kind of talks to just like how substance use is so womanized against women, so weaponized against women, and how that often keeps them in the dark of like receiving the health and social care that they need. Jocelyn, I really liked your point about clinical advocacy, clinician-led advocacy, or clinician advocacy, sorry, I think you called it. I was just wondering, could you give us some like practical examples of what that looks like on the ground, like thinking about, you know, clinicians who might be listening right now, like what are some practical things that they can do within their service or hospital?
Yeah, absolutely. I think the example that Elvira, who is our AOD peer lead, gave to me was that you know, we're normally mostly contacted to give feedback on clinic attendance, for example, but you know, there might be really legitimate reasons why patients aren't able to come to meetings on time, or there are barriers that need to be addressed. And often that sort of context isn't heard when it comes from the patient. Whereas if we as clinicians step in to explain the context and explain just how hard a person is working, and that there are wait lists or other barriers that they can't address, we can we have a really powerful role to advocate for them in that space. And I guess I can also give another example where I have failed to advocate for a patient in the past, and in hindsight I would do things differently now. But this was actually a father who came to me in clinic who had been told by child protection that he needs to do AOD counselling for his alcohol use in order to gain access to his kids, but over repeated clinic appointments with me, he did not have an alcohol use disorder. I referred him anyway because that's the box he needed to tick in order to have access to his kids, but I really should have just contacted child protection and been like, you know, why put this person through AOD counselling when he doesn't need it? So yeah.
So interesting. Oh my God. Great examples. Thanks, Jocelyn. And Louise, this is such an amazing program, and you know, since hearing about that program, having conversations with people, I've had a number of people from Victoria kind of say, I know someone who's in a position where they're trying to get their kids back and they've got no peer support to help them. I wondered, one, what's the sort of remit of CAHMA in terms of being able to support people outside of Canberra, if there is one at all, or do you know of services outside of Canberra that have like a similar program, or perhaps what could services, peer support services, do to expand their capability? Sorry, that's 3 questions bundled into one, but I'll hand it over to you.
Yeah, no, that's okay. I mean, look, so there are a lot of peer-led organisations. There is one in every state that I'm aware of. I'm not sure if they run a similar program to ours. I think ours is a little bit niche, I guess, but I think it's also because a lot of the peers that work here have come from that child protection space and had some good success in that space. But look, we'd be more than happy to pick up the phone and offer someone some support, or do some online stuff as well. Most definitely, because I think it's sometimes you just need that person that can give you a bit of strength and hope and listen to some concerns and maybe offer alternatives and things like that. So I'd be more than happy to reach out to them via like a Teams meeting or something. Anything to help a woman get sort of restoration of their child is what we like to see. 100%.
Amazing. That's really exciting. And yeah, like, you know, I was reading a paper the other day about how, you know, the top priorities of people who are entering drug and alcohol treatment, and the top 4 that I read were reunification with their family, or their family in general, family and domestic violence. Like, these are the key concerns of people who kind of enter AOD treatment, but I assume, you know, people who are accessing harm reduction services as well. So I'll just kind of do another shout out. If you have a question, I've got someone. Sorry, so Samantha Jones, please contact Harm Reduction Victoria. If we don't do it, we will find someone who can as peers. And asking a GP ends in them blaming the OAT. Sorry, Samantha, I'm not entirely sure. Asking a GP.
I think that was in relation to the menopause point. So women seeking advice from their GP that might be coming in. Yeah, just talking about hot flushes could be then the GP might say that it's caused by their OAT rather than actually unpacking what might be happening and speaking to them about menopause. Yeah, thanks, Samantha.
Yeah, sorry, Samantha, that makes total sense. And just as well to reiterate, Pearl, so the CAHMA equivalent would be, yes, peer-based organisation, Harm Reduction WA, who are also wonderful. And I'm sure, you know, the level of experience that CAHMA has had and success that CAHMA has had could be sort of shared around the harm reduction organisations and peer-led organisations that maybe don't have the same experience too. So if there's no other questions, the one other thing that I kind of wanted to do quickly, and just to note that we will finish this 5 minutes before the hour if there's no other burning questions to answer, but I suppose I just wanted to get some of your reflections, Jocelyn, on some of the results that Ash was presenting on terminations and pregnancy. We saw this really high number of high rate of terminations within the supermix cohort, relatively low birth rate. And, you know, perhaps you can, you know, pass the buck, but I just wondered if you kind of had any reflections on that and maybe any clinical experience to draw on there.
Yeah, that's a really good question. And not being a super expert in the field, it just, it seems to reflect to me the broader pattern that we do see among people who inject drugs, which is that maybe there's lower access to routine or preventative care and higher access to acute or emergency care, and there's really good reasons for that, I think. environmental and psychosocial barriers to accessing care and the stigma they experience when they try to access care means people often put off care until they really need it. I don't know if Louise has any thoughts about that as well.
Yeah, look, I mean, coming from someone who had quite extensive problematic drug use, with my fourth child, I didn't realize I was pregnant because I wasn't putting on any weight and that kind of thing. I was in a full using problematically at that point in time. So with my fourth son, who probably really changed my life, if anything, it was too late to get any kind of I didn't think I could fall pregnant. I was quite old, so I was a little bit naive around that. But also, even if I wanted to have terminated, which I'm really glad I didn't, it wasn't. I had gone past that due to the space that I was in at that point in time, both like mentally and physically. Yeah.
And Louise, that kind of like prompted another question that I had around kind of CAHMA services around sexual and reproductive health. What kind of offering does CAHMA have as a service for women specifically around this area? And maybe what do you think like harm reduction services could potentially do more when it comes to sexual and reproductive health?
Yeah, so what CAHMA does here is we do have a GP that is accessible by bulk billing that comes in on a Thursday. It is a male, but he's very much attuned to the cohort of people that we sort of provide a service for. But what we did see is there is a lot of, shame and some women obviously don't want to see a male, of course, which is understandable. So we also have every 2 months a sexual health clinic come in, which is just run by women to be able to sort of have those conversations. We do support women to go and to GP appointments, and we really try to minimize the feeling of shame and stigma in this space, and we do try to mentor and encourage people when we can see that something's not where it needs to be, but we do provide, like I said, the GP on a fortnightly basis, and then we also have the sexual health clinic that comes in and can provide that service, which is run by females, and no Medicare card or anything like that is needed. So we definitely try to make that easy and accessible, and we found that that's had quite a big uptake since bringing it in. Definitely.
Amazing. That's great. And just a quick question here from Pearl for you again, Louisa. Who funds CAHMA?
So there's a couple of streams, but it's the CHN and then government funding. Yeah.
Right. Beautiful. Okay, well, just to quickly plug next webinar, I think, God, dare to share a slide during this presentation. So in August, we have an amazing session on scale, reach and equity in drug checking, learning from international models. NDRI's PhD candidate, Caitlin Dooley, will be facilitating this session and talking to Professor Bruce Wallace and Dr. Nebaran Dasgupta from Canada and United States